strategy for patient-oriented research. I'm very excited to be here today and hear from our presenters, Sarah Kirby and Mpho Begin. Just a note to ensure that everything works with WebEx, please mute yourself if you haven't already been muted, and turn off your camera to help ensure we don't run into bandwidth issues. If you have any questions or connections issues, you can type them into the chat box and a SCPOR staff member will assist you. Also note that today's session will be recorded. If that's going to cause any issues for you, then you can message Brittany Walsh and she'll help ensure we remove you from the recording or deal with that appropriately. So to start today, I'd like to take this opportunity to acknowledge that the event is being hosted from Saskatoon, Saskatchewan, which is located on Treaty 6 territory. Treaty 6 is the traditional territory of numerous First Nations, including the Cree, Anishinaabe, Nakota, Lakota, and Dakota peoples. Treaty 6 territory is also the homeland of the Métis people. So personally, my ancestors came to this area from Ukraine around 120 years ago. And in coming to Canada, then they escaped discrimination, oppression, and genocide. However, I also acknowledge that as settlers on this land, just their presence here contributed to the oppression and genocide of Indigenous peoples. As someone with settler ancestors, I've recently started to look for ways to integrate reconciliation into my day-to-day activities. And one small way I'm trying to do this is by engaging with the more Indigenous art. So one of my favorite artists right now is an Indigenous group called Black Belt Eagle Scout. So if you're looking for some new music to check out, I would highly recommend them. So next, I'd like to take a minute to tell you a little bit about SCPOR. If you're unfamiliar with SCPOR, then we support patient-oriented research in Saskatchewan, and we offer a variety of supports. And these include things like recruiting patient partners to be members of research teams, helping to fund students or trainees doing patient-oriented research, providing consultations on engaging in patient-oriented research, offering patient-oriented research training and training on how to build research relationships with Indigenous communities. And then we also have a community of practice or network of researchers conducting patient-oriented research, and we call that the SCPOR Affiliated Researcher Alliance. And finally, we host learning events and workshops like the one that we're hosting today. If you want more information about any of our supports, you can reach out to any of the SCPOR staff, or you can visit our website at scipor.ca. I'll also note that today is our second in a series of workshops on learning health systems. As SCPOR moves towards the second phase of our grant, we'll have a new focus on fostering a learning health system environment. I'll let our presenters provide a little bit more in-depth definition of a learning health system, but CHR defines a learning health system as an integrated health system in which progress in science, informatics, and care culture align to generate new knowledge as an ongoing natural byproduct of the care experience, and seamlessly refine and deliver best practices for continuous improvement in health and healthcare. In preparing to support a learning health system, we're going to continue to host a number of workshops over the next year to build a shared understanding of what a learning health system is and how it fits into the Saskatchewan context. Today's event will start with a 30 to 40 minute presentation by our presenters, and that'll be followed by 30 to 40 minutes of questions and discussion. So once again, we ask that everyone keep their microphones muted during the presentation and add their questions to the chat so that they can be discussed following the presentation. And then after the presentation, we ask that everyone either use the raise hand function, in which case we'll call on you to unmute and then ask the question, or you can just type it into the chat, whichever you feel more comfortable with. So our presenters today are Sarah Kirby, who is the Health Quality and Patient Reported Measure Lead at the George and Fay Center for Healthcare Innovation, and Mpho Begin, who is a patient partner with the George and Fay Yi Center for Healthcare Innovation. I'll turn it over to you two to start the presentation.
Thank you very much. And I think I successfully unmuted myself. Can you nod and assure me that I am unmuted? Yes, okay. So thank you very much for this opportunity, and thank you for the Saskatchewan Centre for Patient-Oriented Research for this opportunity to speak with you today. I am speaking from Winnipeg, Manitoba, with my partner Mpho Begin. I'm on Treaty 1 land, home of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and homeland of the Métis Nation. Today, Mpho and I are going to be focusing our conversation on patient-reported measures. What are they? What they're not? Why they're important? How they're used? How they're an important part of patient-centered care. Mpho is going to talk to you a little bit about our Manitoba patient-reported measurement strategy, how people with lived experience were engaged in the development of that strategy, but also how they are embedded within that strategy. And finally, we're going to touch on a learning health system and how patient-reported measures fit into a learning health system. I'm going to start the presentation off today with a story to help illustrate the concept of patient-reported measures. So we're going to follow Shauna through her experience with Manitoba's healthcare system, keeping in mind that our goal is to provide her with high-quality, patient-centered care in a cost-effective and efficient manner. So Shauna has been experiencing terrible symptoms and clinical markers of kidney disease. She lives in a rural and remote community in Manitoba, and her family physician has referred her to a specialist in Winnipeg. So she's traveled to Winnipeg to see this specialist, and sure enough, she is diagnosed with chronic kidney disease that requires dialysis. And the specialist in Winnipeg has strongly recommended that she receive dialysis, receive in-center dialysis, which is only available in Winnipeg. So like many other Manitobans in this situation, she has had to relocate to Winnipeg to receive treatment. So we're going to catch up with her now. This is a year into her treatment. And we're going to ask ourselves, again, are we providing her with high quality patient-centered care? So the first question is, well, how do we know? How do we measure this? What do we look at? So let's start with the most basic. We know we collect clinical measures and we do a good job of this. So let's look at the clinical measures. Well, from the clinical outcome point of view, Shauna's doing extremely well. All of her lab indicators were within a normal range and her symptoms have disappeared. What are some other things we can look at? Well, from a health systems level, when we're looking at outcomes, we tend to focus on utilization metrics, or we look at cost. And we also look a lot at adverse outcomes. So things like hospital readmission rates or hospital-acquired infections and stuff like that. So at this level, it still looks like we're doing pretty well. Shauna is alive. She's a life-saving treatment. Sure, the cost of it, it's very costly. In fact, it's a very costly service that we provide in-center dialysis. And of course, that means that the volume of care of that particular care has increased, and that might make one think that we might need more in-center dialysis units if the volume continues to increase. So this is the kind of information we have right here. But let's take it one step further and let's ask Shauna about how she's feeling and how she perceives her outcomes. And so when we ask Shauna specifically about her outcomes of care, we find out that she's actually not feeling very well at all. And that from a quality of life point of view, she rates her quality of life very low. She is experiencing a lot of depression, socially isolated, highly anxious. What about her experience of care? Well, it turns out that she really enjoys the clinic staff. Everyone there is very nice, but she doesn't rate her experience of care very highly because she doesn't really enjoy going in to the center for dialysis. And she doesn't actually feel like she was adequately involved in the care decision process, because there are, in fact, other ways of receiving dialysis, and those weren't really emphasized to her at the time that she saw her specialist. So she's just not feeling great. Health outcomes are conventionally measured from a clinical and healthcare provider perspective. Was the treatment a success? Has the wound healed? Are the lab indicators within a desired range? And at a systems level, we tend to focus on either utilization metrics, like I said before, so number of doctor's visits, numbers of prescriptions filled, or we rely on measurements of adverse outcomes. As I said before, like mortality rate being one of the most obvious ones that we measure, but hospital readmission rates and hospital length of stay. So all these metrics, which we focus on and are extremely important and we need to measure, but they don't measure all that is important to the patient. Did the treatment achieve the goals that I hoped for? Was my healthcare encounter respectful? Can I function optimally at work and in my personal life? we can't know if we're providing high quality patient-centered care if we're not including the patient's perspective into the way we measure our healthcare system. And this movement towards using more patient-reported measures within measuring a healthcare system stems from the idea that patients are in the best position to tell us about their outcomes and experience of care. And when it comes to quality, shouldn't their quality of life be included in our definitions of quality? So measuring the patient's perception of their outcomes and experience of care can be achieved through patient-reported measures. And that's what we're going to talk about today. So the next part of this presentation, the next few slides, are going to be a little bit heavy on the definitions, so I'll try not to make that too boring. But we're going to define what patient-reported measures are. So in general, they're validated, standardized questionnaires that provide uniquely patient-centered information about whether the care that we're providing is meeting the needs of those who are using our healthcare system. So they're broken down into two main groups. They're patient-reported experience measures, or PREMs, and patient-reported outcome measures, or PROMs. And I'm going to refer to them as PREMs and PROMs throughout the rest of the presentation. And PROMs are further divided into condition-specific and generic. So let's start with patient-reported experience measures. So these are focused on questions related to service delivery and processes of care, such as cleanliness of waiting rooms or bedside manner, or whether a patient feels that they were adequately involved in important care decisions. And so they're primarily used to measure and monitor service quality. On the other hand, patient-reported outcome measures ask patients to provide information on aspects of their health as it relates to their quality of life. So these would be questions related to their symptoms, to their physical functioning, to their level of pain, to are they able to interact socially in the way they used to, and are they mentally and socially and physically healthy? Those types of questions. And they provide insight to us on the effectiveness of care from the patient's perspective. And so, like I said, they're divided into two types. So generic PROMs ask very general questions about the well-being of a patient. So they're very high-level questions about your pain or your physical functioning. They're very useful for comparing different patients across different health conditions, but they're less sensitive to health outcomes that are specific to a particular disease or intervention. And that's where the condition-specific or disease-specific PROMs come in. They are very specific to a particular sector of care or a particular intervention or disease. So they are designed to be sensitive to change over time and differences between, and they can detect differences between groups of people that have had the same intervention or the same condition, but they're not generalizable outside of those conditions. So as a result, because both of these types of PROMs provide really complementary information, we tend to advise that they are both collected together. And in our provincial strategy, we do offer that as a recommendation, that generic and condition-specific PROMs are both included if you're going to collect PROMs. So this is an example here of a generic PROM. So this is called the EQ5D5L, and it is actually our provincial recommended PROM. So this is in one of the recommendations in our provincial strategy. And what I want to show you about this PROM is, first of all, that it is high level. It's very short. It's only 5 questions, and that means it has a very low response burden. It has been translated extensively into hundreds of languages, including Canadian English and French. It has high cross-cultural validity. There are multiple modes of administration available, including proxy versions for patients who are unable to complete the surveys themselves. And it does allow us to produce a health utility score. And these scores are used to compute quality adjusted years of life, which is what we need to support economic analysis or economic evaluations. And so that's very helpful. The other thing that's really important about the EQ5D, 5L, is that it is actually the provincial recommended generic PROM in Alberta. It's also been recommended by the Canadian Institute for Health Information for collection for hip and knee arthroplasty, along with a condition-specific PROM, and it's being used in quite a few provinces in Canada. So that, along with many other factors, was one of the things that prompted us in Manitoba to choose this as the generic PROM. I put it here as an example of a generic PROM, but also to let you know that we have selected this in Manitoba as our generic PROM of choice. So still on the topic of what are patient-reported measures, patient-reported measures are like other clinical measures. They're standardized, validated, reliable instruments that enable a consistent, structured method for collecting information directly from patients without interpretation from a healthcare provider or anyone else. And this information is used to build a clearer picture of patient health over time and a clearer picture of health outcomes across populations. So what I'm trying to get at here is sometimes it's confusing the difference between a survey, a patient survey, and a PROM or a PREM. And the big difference is that, that validity, that process that PROMs and PREMs have gone through, and it's quite a rigorous process to ensure that there are strong what's called psychometric properties associated with the tool, because we want to collect PROMs and PREMs and use them the same way we use clinical tools to measure clinical outcomes. So what they aren't, well, they're not rapidly developed questionnaires. For example, questionnaires or surveys that we've developed in Manitoba to meet emerging needs. For example, surveys that we've developed locally to understand patient experience related to changes in service delivery that we made due to COVID-19. Those are extremely important surveys, and we should conduct those, and we do all the time. And I know Saskatchewan does as well. But I'm just using that as an example here to say that that's not exactly what I'm talking about with PROMs and PREMs. So sometimes it's not easy to be, unless you have ones available that meet your criteria. It's not always a quick solution to pick a PROM or a PREM to answer a quick question that you have. While there are lots of ways to deliver a PROM or a PREM, semi-structured interviews aren't one of them, although interviews may be. But just the emphasis that it's a very structured approach. PROMs should not be, and PREMs should not be made in the absence of patients. They used to be often made in the absence of patients, but that isn't really the case anymore. And they shouldn't really be used as a standalone tool. And I'll talk more about that today, but what I mean is that they need to be linked with other data. That's where you get the value of patient-reported measures. And you can imagine if you're linking it with important data, demographic data, or race, ethnic, and Indigenous identity data, clinical data, what kind of information that you could follow over time, and the kind of information you could have if this data were linked. So just very briefly, how are patient-reported measures used? Well, globally, they're used in conjunction with other health data to evaluate healthcare effectiveness across all levels of our health system, from the individual, the micro level, to the health service, to the health system level. So at the individual level, you see that they're normally collected to enhance patient-provider communication. They're used to inform care pathways for patients. And interesting at this level, there's also a lot more emerging evidence to show that just the act of collecting patient-reported measures actually improves patients' outcomes in the end, which I think is an interesting finding. At the health service level, or the MISO level, aggregate patient-reported measurement data can be used to guide quality improvement efforts for outcomes as well as patient safety. So at this level, data can be used to identify gaps in care, evaluate health programs, assess and monitor the outcomes of groups of patients over time, and evaluate the impact of healthcare services. And finally, at the macro level, Patient-reported data can be used to help policymakers establish and evaluate policies meant to benefit a given population. So this includes comparing outcomes over time, locally, regionally, provincially, informing quality improvement activities at a system level, and performance measurement across organizations within your region or even across regions. Patient-reported outcome measures specifically, so PROMs specifically, are a key component of value-based care. And I don't know how many people here have heard much about value-based care, but that is a framework for measuring health systems performance. So value-based care is about making service and resource allocation decisions to achieve health outcomes that matter to patients. So where patient-reported outcomes are the numerator of that equation, and cost is the denominator. So that is an attempt to illustrate to you that collecting patient-reported measures at all these different levels puts the patient's voice into clinical care decisions, the evaluation of our healthcare service, as well as our healthcare services, as well as the performance of our healthcare system. It really signals a shift in the orientation from a healthcare system that is system-centered or provider-centered to one that is more person or patient-centered. And in addition to that, patient-reported measures provides us with the data that we need to move away from this concept you may have heard from volume-based care to value-based care. And that relates to what I said earlier about patient-reported outcome measures, or the standardized measurement of that is the numerator in that equation. So that leads us to, that's some background on what are these tools, what are patient-reported measures, why are they important, an important component of patient-centered care, but how on earth are we going to do that? Like how do we integrate this into our healthcare system? And those kinds of questions are what prompted the Center for Healthcare Innovation, where Mpho and I work, to start contemplating this question and talking to our local stakeholders and moving forward on this idea of developing a provincial strategy as a starting point. So in 2019, in December, the Center for Healthcare Innovation put together a group of stakeholders. We developed an advisory committee, so a provincial patient-reported measurement strategy advisory committee. And this advisory committee had about 20 people on it from a range of healthcare backgrounds. We did have people with lived experience on this committee, clinicians, data scientists, health quality leads. We had members from the provincial government, from the Provincial Information Management and Analytics Branch, from our provincial health authority, and digital health, which is the electronic e-health equivalent of working with our provincial health authority. I think I mentioned data scientists and biostatisticians and clinicians and quite a range of people. And we got together over the course of 1 year to put together this strategy. So the strategy was informed also by the literature and by what other jurisdictions around the world and in Canada are already doing. It is actually a framework, and what you're looking at right now is the framework. And there was a lot of input from members of the public and CHI's Public and Patient Engagement Collaborative Partnership in developing this particular visual and conceptual framework, and also a series of recommendations with the overall goal to enhance the use of patient-reported measures in Manitoba. So I'm going to hand this over right now to Mpho, who's going to talk about the first 4 components of this strategy. And then I'm going to come back in the middle of data collection and analysis to finish it off. And then we're going to talk about the learning health system. So I'll pass it over to Mpho.
Thank you, Sarah. So I'm going to start by kind of talking about how the public and the patients were involved in developing this strategy. So there were different levels of engagement in which people with lived experience were involved. There was an advisory committee. There were consultations with the Manitoba communities, and also the public and patient engagement collaborative partnership, which I'm part of. We provided input into the strategy and co-developed the partnership and engagement section of the strategy, as well as a standalone engagement resource. Okay, next slide. So in terms of the advisory committee, there were members from the public who participated in the Provincial Patient-Reported Measurement Advisory Committee. They met every couple of months for 1 year and provided input into each of the sections of the framework and the recommendations. There are also consultations with the Manitoba's cultural communities, as well as other groups, and they identified several factors to consider when embarking on a strategy to collect PRMs like this. So some of the examples that they provided was that there's a very overwhelming support for including PRMs in the way we measure healthcare in Manitoba. And also, we need to consider that many Indigenous people in Manitoba do not trust the medical system and may not be willing to fill a surveys during their healthcare encounter. So we need to be aware of this, and one way to address this is to involve them in the decision-making how this data is collected. There's also concerns about systematically including people with low literacy or who cannot speak English if the tools that are being used to collect this information are not translated and validated in their own language. Also need to understand that different cultures respond differently to questions related to quality of life or experience of care. For example, in some cultures, you don't complain about the pain, so the patients may underreport their pain level. They also may not feel comfortable saying something negative about the care that they are receiving, so which could impact the results of the survey. We also need to understand that communication is very important so that patients understand why they're being asked to collect this information and also what that information is going to be used for. So if people understand these questions, they are more willing to provide the information and fill these surveys. Also, once the information is provided, people want to be able to see and learn from the results in a way that is very easy to understand and also meaningful to them. So the CHI's Public and Patient Engagement collaborative group, which I'm part of the group, we provided input into the framework and the recommendations, and also developed a standalone guideline and resource for engaging patients with lived experience. So the resource is available on the CHI website at the link provided above. So now I'll start talking about the recommendations of the framework. The first one was the partnerships and engagement, that we need to engage people with lived experience early on and also at every stage of the PRM initiative. So one of the patients and people with lived experience are central to the Manitoba's PRM strategy. We know that patients and people with lived experience, including caregivers, family members, are key partners in successful PROMs and PREM initiatives worldwide. So involving patients, people who have lived experience with a particular health condition informs our understanding of its day-to-day impact and effects on the quality of life. So these individuals bring a unique perspective and knowledge to the planning table. And also, patient-reported data can be effectively utilized only if patients are first willing and able to provide that information. So when collecting PRM data, so the information needs to be carried in a way that patients are able to understand, and it's not complicated for them, and also it has meaningful value to them. So we recommended that recommendation that patients and public be engaged at every stage of the strategy. So there's different ways that they can be engaged. So the first one is be able to develop a shared understanding of the purpose of why the information is being collected in the first place. And also they can be engaged by selecting the tools that are going to be the PROM and PREMs tools that are going to be used to collect the data, and also ensuring that patients are going to be willing to accept those tools and be able to use them. So things to consider, keep in mind when selecting tools is that cultural appropriateness, and also it's going to be easy for the patient to use, so there's no response burden. I also have to consider the literacy level and the real world context in which people with lived experience and their families live, work, and play. We also need to make sure that the tools are validated and available in multiple languages, so that all the voices are heard and included. We also need to confirm that PRM content addresses health outcomes or experiences that are relevant to the patients and captures this in a comprehensive and understandable manner. So another way we can engage the people with lived experience is the data collection strategies, whether they're going to be using paper-based or electronic method, or even using telephone surveys. Okay. So when looking at the data collection, also we need to identify barriers and also find solutions to those barriers to ensure that all voices, especially those of marginalized voices, are heard. We need to choose communication strategies that's going to enhance participation, and also make sure that patients, when they start filling those surveys, they can complete that survey and provide all the data. Another way patients can be involved is the reporting outcomes, be able to identify potential barriers and contributing to developing solutions to ensure that results are reported in a meaningful and appropriate way. And also ensuring that results are reported using plain language before dissemination. Also contributing to communications and KT knowledge translation strategies that will enhance the use of PRM data by clinicians, patients, administrative and health system leaders. So that was the first recommendation, to involve people with lived experience. The second recommendation also involved being able to involve a multidisciplinary team early on and also in all stages of the PRM strategy. So we know the implementation of the PRM initiative is inherently a multidisciplinary endeavor that requires input and advice from a range of healthcare professionals, researchers, information IT expert, statistician, and communication consultants, patients, and individuals with lived experience. For example, including early on statistical experts will ensure that the data that's collected can be analyzed appropriately according to the intended purpose. And involving nurses and clerks, those are the ones who are often involved in collecting data from the patients and can inform data collection strategies. And then information technology experts are required to support data collection strategies And then finally, the knowledge translation aspect informs strategies that enhance the dissemination and uptake of the PRM data. So as mentioned earlier, patient-reported outcomes have value across the healthcare system, from individual patient level to the health system level. So while ideally PRM strategy will meet the needs of all stakeholders, it is feasible to start with just a few focused objectives and then scale up over time. Therefore, understanding why PRM data are being collected and how this data will be used is a fundamental first step that will guide all subsequent decisions, including the selection of PRM tools, the timing, frequency, and mode of data collection, data analysis, and how data will be reported and used. So understanding each partner's motivation for using PRM data can enhance implementation and also encourage buy-in. So in this section, I've talked about, we made the recommendation, the first one being engaging patients with lived experience, and second one, also having a purpose, developing a shared understanding of why why you're collecting the PRM data. And then the third one that I'm going to talk about is the measures and tools. As Sarah mentioned earlier on, the recommendation that we have is to use the EQ5D5L to collect generic PROMs, and also use both the generic and condition-specific PROMs together whenever possible, as they provide complementary information. So there are hundreds of PRMs to choose from. So how do you select the right PRM? When selecting a PRM, there are several considerations that can be used to guide. So yeah, this is maybe Sarah can talk more about this later on, but this is the checklist for selecting the PRMs. A lot of consideration goes into selecting the PROM and/or PREM tools to use, and selection should include the multidisciplinary team, including people with lived experience with the condition. The Provincial PRM Strategy Advisory Committee developed this checklist to help users to select the PRMs. So selection should also be guided by the literature and the provincial checklist for patient-reported measurement selection. So some of the things to consider is the level of psychometric evidence, which is reliability, validity, and responsiveness. Be able to track, have a track record of widespread use and selection implementation. The questionnaire content, such as questions, will provide the right data to respond to a specific objective. So when selecting a PROM, both the generic and condition-specific PROM should be used together. Also need to consider patient acceptance. We talked about being cultural appropriateness to reduce the response burden, and also have the right literacy level. And the questionnaire content should also consider the clinical, clinician, and patient needs. The tool also needs to have to be validated in multiple languages so that it can capture all patient voices. It needs also to be feasible, things to consider like licensing fees, data reporting requirements, how much it costs to implement, and also to administer administration time and resources in analyzing that data, and also the patient response burden. So also have to consider the clinical and health system applicability. And patient engagement needs to be, patients need to be engaged also in selecting these tools as well. Okay, next slide.
Thank you, Mpho. I think is this the part, I think this is the part where I am speaking, am I right? Or wait, are you on part of
yes,
this?
I covered the first three, so I'm gonna let you cover the last two.
Right, I forgot. Okay, go ahead. Sorry for the interruption.
It's okay. So yeah, overall, there were 5 recommendations that were done. I covered the 3. So now I'm just gonna let Sarah finish off the last 2.
Okay, so I'm going to cover the data collection and analysis.
Yeah.
Okay, so there we go. Okay, I see where we are now. Okay, so thank you very much, Mpho. So up to now, we've talked about, actually, I'm not sure, did we, I think we might have missed the recommendations here. Maybe I went ahead on a slide, but we have recommended in our provincial strategy to use electronic data collection tool that is integrated with electronic medical records and provincial data assets as the way to go for collecting patient-reported measures. And that's a pretty bold statement from our committee because we don't have any provincial mechanism for electronically collecting data, PROMs and PREMs data. But looking at the literature and speaking to other people and talking to patients and having this experience of COVID, we know there are a lot of benefits to having some electronic option. We know that that's not going to be okay in all parts of the province. There are people that don't have access to the internet, and so paper-based will always be an option there. And there are obviously other ways to collect PROMs and PREMs. But there's quite a bit of efficiency when you can collect a PROM and it is integrated with the electronic medical record. It makes it, and we talk a little bit more about this in a learning health system. That's part of the importance of data. Data is really the driver of a learning health system. And if we're really going to integrate patient data into the way we make decisions, we need to have an efficient way of having that data be able to link with other data so we can answer important questions. So that is an important recommendation. We also recommended, this is not a research endeavor here. We're talking about the routine collection of patient-reported measures. And so you don't need to go through ethics, et cetera, if you're just collecting for those reasons. But we do still recommend privacy statements. So we've provided a privacy statement, a proposed statement in French and English in our recommendations. And finally, because of this importance of linking data that I've talked about quite a bit through here, we do provide a suggested minimum data set to accompany the collection of data so that you are able to link data to other provincial assets. So that usually means collecting a personal health identifier. We also provide an accompanying data dictionary to support linkages with different databases. So, and I'm sorry, Mpho, I think I jumped in there. I was getting lost because we kind of split it at this really awkward point in the strategy. And so I realized you were going to speak to those points. And the reason I wanted Mpho to speak to those points is because from the patient perspective and from the work that Mpho does, she has a lot of experience with data and health data, and she's done some projects around this. And she, like the rest of our team, feel very passionate about the importance and the ability for us to link this data. Sometimes the conversation gets really bogged down in issues about privacy. And while privacy is so important, we need to understand that we're collecting all kinds of private data and linking it to your patient record. And those people, clinicians who have access to that patient data aren't using this inappropriately. I think that there's concern, especially around the collection of patient-reported experience measures, that a patient may not want to tell their honest-to-goodness opinion about their experience if they think that's going to be tied to their record. So we need to talk about privacy and access to data. There needs to be governance models around that, but we know we can do it, and we do share private information all the time. And Mpho, I don't know if there was something you wanted to add related to that.
No, I think you covered it well. I guess, yeah, the main concern with data sharing is privacy. Patients are trying to understand who's going to have access, why, and it's going to be, you know, the data can be identified. They can be identified from the data. So I think, yeah, like, I mean, technology is going to be the go-to if you're going to be using recommend electronic collection. Obviously, we can't shy away from talking about privacy, and that also shouldn't prevent us from moving forward with that, with the technology. So, yeah.
Right, and there are ways that we can do this in a privacy appropriate manner. So just the last little bit I'll touch on really quickly because I'm looking forward to getting to the learning health system part of this presentation. I'll just talk about frequency and timing. So typically patient reported measures are either collected at pre-post intervention. So when you're having a discrete treatment or service, like surgery is the most obvious one, or they're collected longitudinally at different points over time. And so you can imagine this would be considered in a case where you have a more complex intervention, such as someone dealing with a chronic condition, so in chronic care situations. And the final one is a cross-sectional approach. And you find this more often when you're collecting PREMs at a large level. And so there's lots of things to consider when it comes to the timing. That's the timing. The frequency is then how often would you collect it. So if you're doing it pre-post, is it just pre-post, or is it pre and then 6 months, 1 year, 2 years, 5 years after? Same with longitudinal. How frequently do you collect it? Well, that will depend on the purpose for why you're collecting it, the clinical context, the resources available. You have to take into consideration the burden of data collection on patients, on the healthcare professionals. You have to, and we know that approaches that integrate data collection into existing processes as much as possible have higher rates of success than those that do not. And so that's, again, part of where data collection and using an electronic system, especially that can be embedded in the EMR, or something easy for patients to use, we know is far more successful. And finally, I'll just touch on this bullet on the screen that talks about a census-based approach. That means what we recommend in our strategy is that everyone, that's a census-based approach, everyone receives the PROM. So everyone receiving the service will conduct a PROM or a PREM. If a sample-based approach is required, then our recommendation is to consult a biostatistician to make sure you're getting the right sample. And finally, last but definitely not least, is the reporting and use. So we know that the success of a PRM initiative is going to lie not only in the successful collection and analysis, but that the way that this information is translated into knowledge and used to advance patient care and health systems goals is going to be challenging. This is the world of knowledge translation. It is challenging. The literature is full of barriers and facilitators to successful reporting and use. And so we did put together a table in our strategy to highlight those barriers and facilitators as a tool. We know that a recognized facilitator for analysis and reporting is to have support from a central data analysis unit. That support includes interactive tools for analysis and presentation. And so we're working really closely with both our provincial government and our shared health, our provincial health authority, who both have shared responsibility right now for analysis. And so they are on our team, and we are actually doing some pilots to look at how we could use analytic tools and where people would go for that support. And we can also provide some of that support right now through the Center for Healthcare Innovation. And then we also know that we need to use really best practice in communication and knowledge translation. So those include things like you need to tailor messages to your specific audience. You can't take the results and send them to patients in the same way you do to the provider or to the health system leader. So we need to encourage uptake. We need to ensure that we are being very tailored in those messages. And finally, another lesson learned in the literature that we are going to follow and have recommended here is that it's not enough to just report the results. Clinicians, health systems leaders, everybody would like some guidance on how to interpret those results. So we understand that that's important. So that gives you a quick overview of our strategy. I will share the link to where you can look at the strategy in the next slide. There's a lot more detail, obviously, in each of these areas, and we're just providing a bit of an overview. This is our vision. We know that however compelling this vision is, it's going to require considerable collective effort. Each of these stages of a PRM initiative brings with it a range of operational, methodological, and practical challenges that we know we need to address. And we haven't even touched on the methodological challenges in this presentation. It could be a presentation in and of itself, but at the CHI in Manitoba, we do have some great expertise and people who have a lot of experience around methodological challenges with PROMs and with PREMs as well. So one of the things that we know that will aid our success in achieving this is to embed this within a learning health system. And so that's going to be the next quick portion of this presentation. This is the link to look at the strategy. Okay, so let's switch gears a bit here and talk about a learning health system. So Chris gave a definition at the beginning of our presentation today. This is a very, I find a simpler definition that I have on the screen. The definition that you often hear comes from the Institute of Medicine, which is now the National Academy of Medicine. It's a little bit more of a complicated definition, but I think it's worth stating it. So that is that the science, informatics, incentives, and culture are aligned for continuous quality improvement and innovation, with best practices seamlessly embedded in the delivery process and new knowledge captured as an integrated byproduct of the delivery experience. Wow, so that's a lot, and that's why I didn't include it in the slide, and that's because it leads us to what we know to be true, and that is that learning health systems are complex. In fact, when I was looking for a framework to include in this presentation, I didn't want to include any of them because they're so complicated, and I don't know if anyone listening today has taken a look at some of these frameworks. I actually just took the hub of a framework from the Learning Healthcare Project because I like the simplicity of this. But the truth is that learning health systems are complicated, and there is no one size fits all model for building a healthcare system or a learning health system. They're complex by nature. They have to be co-designed with local stakeholders, including patients. But this concept, the title that I have here, this concept of learning while doing has really exploded. I mean, it's been around for a long time, but it's really rapidly moved forward since COVID-19. The COVID-19 pandemic has really required us to do two things, and that's learn as quickly as possible while providing the best care. And so learning and doing at the same time. So the problem that we've run into here is that we're working in a system where clinical practice and clinical, where clinical research and clinical care, while intrinsically linked and interdependent on one another, are very separate and remote. So those responsible for the doing, clinicians and the health system, don't really feel the same responsibility for the learning, the randomized control trials, or they might feel responsible for the quality improvement initiatives, and I'm going to get into that a little bit later, but there's just this real dichotomy between those that are doing the learning and those that are doing the doing, at least from a clinical research point of view. And there's very good reason for this up to now. We've had very rigid and strict, processes around randomized control trials, and those have been changing. And COVID has really our need to have quick knowledge, but still use a rigorous scientific process has has caused us to really innovate when it comes to clinical trials. And so there are some amazing new designs out there that are taking advantage of machine learning and artificial intelligence. And that's not the purpose of this talk, but it really does fit into this concept of learning while doing, and having to transform and really blow up the way we are currently doing that. So that's a lot. Let's unpack just a little bit of that. So what are some key characteristics of a learning health system? Like I just said, clinical research and clinical care need to be seamless, not separate. They're not just close to one another in the hospital, but they need to be synonymous, especially in an academic hospital. We need to look at this as a situation where if we're not using the patient encounter to learn from it, it means we're not actually delivering good care. So we need to work as a team, and that is going to require a major culture change. And so that is part of a characteristic of one of the characteristics of a learning health system. Real-time or near real-time patient data is readily available for knowledge generation. And I don't know about Saskatchewan, but that's not available in Manitoba yet. And in most parts of Canada, we're just starting down this path. Clinicians, scientists, researchers, administrators, and health systems leaders need to work together. And that speaks to the points I made earlier. We need to find a balance between rapid, responsive learning and good scientific methods. And that also speaks to this idea of quality improvement initiatives that are often done quickly with questionable methods using limited data. We can benefit from some of the, if we're able to work together, we can benefit from some of the more rigorous processes that come with clinical trials, but the two have to come closer together. So the rigor and 3 years and $200,000 to do a randomized control trial, and then the quality improvement over here, we need to come closer together, and we all need to work together to balance those priorities. And finally, a data infrastructure that enables efficient, routine access to clinical data, allowing for economies of scale. And so these are a few of the characteristics of a learning health system. Currently in Manitoba, data exists like this in silos. It's not integrated. Every time you want to do a project or do some research or a quality improvement project, you have to make these we make ad hoc linkages to our different disparate databases in terms of clinical data. And we know that if patient-reported measures are simply going to go into another silo, like the rest of the data in our healthcare system, then we're no further ahead. So that is why we are partnering with our province. So our province has a vision to develop an integrated provincial data platform. And we have partnered with Mindset, which is a support for patient-oriented research, innovative clinical trial rewarding success team grant. And the purpose of this grant is to support the province of Manitoba to integrate our vast collection, disparate collection of clinical health data into one cohesive, near real-time, province-wide health data platform. And we're doing this through a series of demonstration projects. They're actually innovative clinical trials that will demonstrate and almost work as a pilot to demonstrate the feasibility and scalability of this integrated data platform. But along with this, we are met with many of the challenges that all kinds of organizations across the world are facing when it comes to building a learning health system, or even building components of that learning health system. And that is culture change, helping everybody to see that we're working together, It's not the researchers versus the health system, which it kind of feels like sometimes now, but that we need to work together to find systems of efficiency. We need to create a data infrastructure that enables efficient and routine access to clinical data. This is what we're trying to do here with Mindset. It turns out there are many, many steps and challenges related to doing that. We need patients involved in this, and Mindset has a strong patient engagement component, and each of the embedded clinical trials also have patients that have been involved right from the grant application point right through the entire project. Although I must say we're very delayed due to COVID. So while we did receive our funding in late 2018, we are just starting to get moving on those clinical trials. So when fully scaled, Mindset will facilitate the creation of a learning health system where every patient encounter informs future decision-making in order to continually improve the quality of healthcare provided to all residents of Manitoba. So that's our vision, and that's a big step towards a learning health system in Manitoba. So let's tie this all together here in the end. Are we providing high quality patient-centered care to Shauna? So I'm going to say that at this point, we don't even know, because we're not involving Shauna in answering that question. We've been answering it for her. We have that measuring tape, and we're dictating how her care will be measured without involving her. You can't have patient-centered care without involving patients. And as I have said before, involving them in a systematic, standardized way so that their input is the same and has as much value and importance as clinical indicators do, as blood pressure and other clinical measures. So we can't congratulate ourselves just yet on providing high-quality patient-centered care if we don't have a mechanism in place for systematically collecting the patient's perspective on the outcomes and experience of their care. And we know that, and that's what this provincial patient-reported measurement strategy is about. It is a first step in a coordinated provincial approach where data are collected from patients and made readily available to guide continuous quality improvement, support clinician patient decision-making, and inform policy decisions as part of a learning health system. And that is our presentation.
Thanks, Sarah and Mpho. Give you a big round of applause, but that's tough over WebEx, so apologies for that. But great presentation, and I really enjoyed it personally. I think there's been some questions that have come in through the chat, and we had some questions that were submitted at the very beginning or during registration. So I'll turn it over to Brittany to bring up some of those. If anyone else has questions, feel free to put them in the chat or to raise your hand, and then we can unmute you and you can ask it in person.
Okay, so I'll start off with a question that came through registration. How do we promote integration and partnership with academic programs to be receptive and responsive to PREMs and PROMs?
Okay, I can start by answering that, and Mpho, if you want to jump in at any point, feel free. So I think the question was, how do we engage, sorry, was it academic departments?
It was integration and partnership with academic programs.
Right. Okay. Well, I mean, that is challenging. I think what we feel is like the first step, of course, is having a plan and having a guide like a provincial strategy. It's a little bit about communicating and promoting at the beginning and helping getting everybody on the same page. So it's really hard to promote the use of patient-reported measures and when people don't always understand them or understand how they're used or understand how they'll collect them. There's a lot of complexity involved. So to answer that question, it's very challenging to answer that question because it's a long sort of process of sort of changing people's understanding and engagement with using patient-reported measures. We know in Manitoba, we're just going to start with, I hate the cliche of this, but the low-hanging fruit. I mean, we're going to start by demonstrating how it can be done and why it's important, and we're going to sort of build from there rather than go out and say PROMs and PREMs all over the province, even though that kind of sounded like what I was saying. We know that realistically we'll have to start with projects and scale up, and we're hoping that by doing that we sort of build that understanding and momentum to encourage that use. I hope that answered the question.
Okay, thanks, Sarah. I'll do one more from the registration and then I'll jump over to the chat box. In what ways have you found to reach populations that are traditionally excluded from health measurements? For example, individuals experiencing homelessness or individuals living on reserve or in remote communities.
Okay, so I'll just say that we aren't, this is not us collecting PROMs and PREMs yet. I do have, as part of the appendix of our strategy, I do have a list of some of the programs that are collecting PROMs and PREMs systematically in Manitoba, but essentially we're not doing that yet in Manitoba. We don't have a systematic approach. And so I don't know. I mean, all we know is that when we went out to communities, we heard that this will be a challenge, and it's a challenge we need to address. And so we've acknowledged that. We know that there'll be different ways, so we have to be flexible in the ways that we collect this data. We feel that involving people with lived experience and experience of the particular condition that you're collecting is going to encourage more of their use. Sorry, that they'll be more likely to use and fill out the patient-reported measure. When it comes right down to the rubber on the road, when the rubber hits the road, it'll be very program specific. And so I'm talking at a very broad system level. We need to be aware that we don't want to systematically exclude people like that. And so there are many things we need to consider. But each program, I mean, if you're a program looking at collecting PROMs and PREMs for mental health, you're going to have more of these issues that you're going to need to address. And I'm not an expert in that field. I've never collected PROMs and PREMs where I'd had to deal with that particular issue. So I have to answer that I'm not sure, but know that we do recognize, and that came out with our consultations, that these are things that we need to be aware of.
Okay, so on that topic of, sorry, Chris, were you? Okay, we're good. So on that topic of mental health PROM, there was a question in the chat box that did ask, is there a mental health PROM that you recommend?
There are lots of mental health PROMs and PREMs. And again, I'm not a clinician, I'm not a clinical expert. So our recommendation as a committee is that anytime you're going to collect a PROM or a PREM, you have that clinical expertise around the table, of course. You engage people with lived experience, you look at the literature. There are some links that you can go to within our strategy that can link you to where there are samples of well-validated, well-used PROMs and PREMs, and I know there are lots for mental health, and it's a real exercise. Each PROM and PREM that you select, it requires some thoughtful consideration, and so I have not done that for any PROMs related to mental health, so I can't specify a particular PROM in that area.
Sarah, that was actually me who asked the question. So you mentioned there's a document I can refer to. Would you mind letting me know again what that document is, and I'll take a look at the examples that are listed there?
Yeah, so there aren't particular examples listed in our provincial strategy, but there is a link in our provincial strategy under the data collection tab that can link you to a broader collection of PROMs and PREMs. So I don't know, maybe Brittany and Chris, if we share the presentation after the link is in there, but we're at chimb.ca. And then chimb.ca/PRM for patient reported measurement. And that's where you can find the measurement strategy. but I can also talk to you offline about ideas of where you can look. Even just doing a simple literature search for validated PROMs in mental health will help you find a whole selection of PROMs that are validated tools.
Awesome. Thank you. I'll connect with you offline then, Sarah. I really appreciate it.
Okay.
Thanks, Ashley, for your question. So the next question from Joan Bartley, how many patients are recommended on a research team or working group?
That's an excellent question. Mpho, do you want to did you want to answer this at all? Mpho, it was on our Public and Patient Engagement Collaborative Partnership and has been involved in some of the writing in that section of our strategy. She's probably trying to unmute.
Oh, you're
still
muted. There you go.
Okay. Do you mind repeating the question? How many patients are recommended in the research?
How many patients are recommended on a research team or working group?
Oh, I don't know if there's a set number for that. I think it just depends on what that research is to be able to determine the number of patients. Yeah.
So we have created a standalone engagement tool that is available on our website. And again, maybe I could put this in the chat somehow. I'm really proud of this. Our Public and Patient Engagement Collaborative Partnership developed this standalone tool, and it does help to answer those questions in there. It is a bit of a balance. You don't, maybe just there is a balance, and we get into describing that a little bit more in that document. It depends on the size of the overall committee. You may even want to have a separate committee of all patients. So in a research project recently, and it's not just a research, it's a health systems project, it's one of the innovative clinical trials in Mindset. One of them is about actually increasing the amount of home dialysis going on in Winnipeg, or in Manitoba, that is, because we do a very low rates of home dialysis. And we involved patients in selecting our PROMs and PREMs tools. And we actually had a whole separate patient committee of about 8 or 9 patients. We have very active patients in chronic kidney disease. They're very engaged, and they've been quite engaged through the whole process, and will stay engaged. Not every, if you're collecting PROMs as part of, hip and knee surgery, maybe you don't need an entire, committee of people. Maybe you have a small committee and you only have one member from, one clinician and a nurse and a data scientist and a patient. A patient or two. So it is a little bit of a science or an art and not a science. So I'm sorry that I'm not being very clear on all my answers. I don't think, like Mpho said, there isn't a set number, but really depends a lot on a lot of the circumstances related to the question and the size of your project.
So Sarah, I can add that standalone tool to the list on what we can include in the email that we send out to registered attendees. So if you send that link afterwards, then I can share it with the rest of the group.
Okay.
Okay. So a next question from Scott Corley. Can you talk about how you validate a PRM?
Yes. Okay. That is a long and complicated process. And I just want to say again that I'm not an expert and I'm not a data scientist, but we do have data scientists at the CHI who actually do this and have been involved in this. So when we put together our provincial strategy, they told me to stay away from validation. So this is like a scientific process. It's like on a long process. I know a little bit about it from reading in the literature. It's you need to. I mean, the steps are quite long and cumbersome, so I'm not sure that I can answer them in a quick, nor am I, an expert enough to answer them. But, it's ensuring that you've met those internal and external validity, ensuring that your survey is reliable over time. So there's many tests. They run the surveys in multiple groups over time. So there's a whole systematic approach to validating a PROM, and there's people that dedicate their lives to doing that. And I'm not one of them. So I'm sorry, there's another question that I can't fully answer. It is rather big and complicated, but I want to just make sure everyone understands that this is the high level. This is the inspiration, the vision. Now is the part that's going to be hardest for us in Manitoba as we take those steps towards implementing this. But certainly we will not be involved in validation, and we're not recommending that anyone try to create or validate a PROM. And if you want to do that, that's some other education that you need that I can't provide or we can't provide out of the CHI.
Okay, another question. The next one is from Paulette Hunter. I'm curious how your team is engaging clinician scientists given the siloing of research and healthcare.
Okay, well, we've been really lucky because the Center for Healthcare Innovation, we kind of have one foot in each door already. So we already support a lot of clinician scientists in the work we do. We provide some research project management for them. We actually have a clinical, like a clinical research unit within our center. And we have relationships with clinician scientists. And like Saskatchewan, we're small enough that once we've built those relationships with them, we have engaged them quite a bit, and they're quite engaged in this, especially in the development of a learning health system. In fact, I think they're leading that. They really see the value of that. What's maybe harder is engaging our health system. So we also have our foot in that door, and we're funded by the provincial government and our health authority, the shared health, our provincial health authority. That's more challenging. It's not that they don't want to be engaged, and they're definitely around the table. It's that that is a major barrier, and we've spent a lot of time building these silos. And so that's about communication. That's about learning. We're also in a pandemic where everyone's distracted, and so in defense of our healthcare system, they are very distracted. But this would be in my week. This is what I spent the biggest challenges of my week with pushing forward, especially the trials within Mindset, is engaging our health system. So bringing, because they're not necessarily trained in these concepts, and they're very there's very much still a culture of those researchers or the us versus them. So once again, hard to answer that question because it's hard to do, and we have not achieved that in Manitoba, but it's what we hope to do, and we're making some progress. Communication is key, and keeping them on your team and engaged from the very beginning of any project.
Okay, the next question is from Lisa Chen. It's a two-part question. So she said, I wonder if you could provide an example of PREMs. Also, is it compulsory that we use proper tools to measure either PROMs or PREMs? If we use a semi-structured interview developed by the team to explore patient experience of the care, can I call it PREMs?
Okay, I have to admit that I do have a little bit more background and knowledge about PROMs than I do about PREMs. My short answer to that is going to be no. Once you start messing with a patient-reported outcome or experience measure, you risk the possibility of making it no longer a valid tool. So you don't know that these tools need to be validated, not just as standalone tools, but then they need to be validated in different populations. If you want to take that tool, that's a paper-based tool, and now you want to do a telephone interview, there's a validation process that goes on when you use it as a telephone tool. Having said that, I think that some jurisdictions do that, and I think they do call it a PREM. not being an expert in that, I don't know if there's more flexibility in the world of PREMs, but I know in PROMs, you can't start changing the questions very much. Sometimes there's a little wiggle room. So an example of that is the Canadian Patient Experience Survey for inpatient care. And I don't believe that Saskatchewan is collecting that data. I don't think you're doing that in Saskatchewan, but this is a national survey that many provinces are using. It was developed by the Canadian Institute for Health Information, and Manitoba's been collecting it for like at least maybe even a decade at this point. And you can easily look that up on CIHI's website. So that is an example of a patient experience tool. So it really focuses more on the patient's experience of their inpatient care. Now, that tool has been developed in such a way that there's a buffer of about 5 or 6 or 7 questions that provinces can add so that they can make it a little bit provincial specific. That one has been validated to be implemented both by paper or through an electronic link. So I'm going to say, I think that the more you change a PREM, a validated PREM, you have to be very careful. Some organizations that have created the tool and have validated it will have instructions with it. So there may be some flexibility. So again, it may be a matter of, if you found that PREM and you want to alter it, to contact the person who developed it to begin with, to get more information about that.
Okay, so just a quick follow-up from Lisa. If we use PREMs, would it usually belong to qualitative research? For me, measuring experiences would be more qualitative research. Thanks for the clarification.
Well, why these measures are not qualitative is that we are asking, we are like the scores themselves are become like a number score. So it's not they're not open-ended questions, for example, for the most part in a validated PREM. Again, I'm not as experienced with PREMs, but PREMs are not part of qualitative research. If you were to have a more open-ended conversation and you were to collect a script of information from a patient, and then you're to review that and analyze it, that's more of the qualitative research side of it. But the reason that this is more quantitative is that we get a score, and scoring these and having that score as part, sometimes having that composite score as part of the patient record can be very important, because that helps with interpretability. And again, that my background is a little bit more on PROMs than PREMs, but that's how they work.
All right, so we're coming up to 2 o'clock here, so maybe we'll fit in 1 or 2 more questions before we wrap it up. Brittany, do we have a few more from the chat? It looks like it's been pretty busy there.
Yes, we do. We do have a follow-up question in response to some of the questions asked by co-participants. I wonder if partnering with clinicians, scientists, and academics would be a straightforward path to locating validated tools or validating tools you're developing. And I completely agree that coordinating nationally on this is a good idea, so that we're not all building our own.
Yes, so you're absolutely right there. Like I just presented prior to this presentation, and I presented with a clinician beside me. They're the drivers of this in a lot of ways, and she was the expert. She talked all about the appropriate PROMs and PREMs in her field, and it was renal transplant. It was the topic area. So you hear me stuttering a bit here because I'm not a clinician and I'm not an expert, but we do rely on our clinicians, and they absolutely are a necessary part of that team when it comes to collecting a PREM or a PROM. Probably most importantly with a PREM, with a PROM, but also for the PREMs. So they have that clinical expertise. They've probably been exposed to this. I mean, the collection of PROMs, especially, but also PREMs, has been around for a long time in clinical research. It has a long history in clinical research. So many clinicians are very familiar and comfortable with PROMs and PREMs. It's more our health system side that don't have the same level of comfort or experience.
Brittany, I noticed that Anna Chan has her hand up in the chat, so I don't know if we think we have time for Anna.
Hi, I just want to ask a question. Sarah, do you think Interray is a PRM tool?
Do I think what is a PRM tool?
Interray, R-A-I, Interray.
I'm not sure. Oh, okay. I see it in the chat there. I don't know what that is. I'm sorry. I don't know what Interray is.
That's like home and the community care agency use this tool to do assessment for patients. They usually ask lots of questions regarding like mobility, self-care, activities, function, pain, like the questions in EQ5D. That's all the report from patients. So I think that could be considered as a PRM tool, but I'm not sure.
Well, it may be. I see it. Thank you to whoever put it in the link. I'm going to quickly look at it, but we can continue with our conversation and maybe I can answer that really quickly. I'm just going to copy the link and open it in another window here so I can take a quick look at it. It could be. I'm sorry that I don't know the answer right off the top of my head.
It's okay.
Brittany, do we have one more question from the chat, and then we'll wrap it up?
Yes, we actually have one from the registration. How can patients be asked about their health and different abilities in a way that is empowering and not disease-focused?
Well, that's a very good question. You know, that's a loaded question when you ask how can it, in ways that can be empowering. I mean, again, we have there are other ways to engage and talk to patients outside of PREMs and PROMs and outside of their clinical experience. I think the fact that we might even just ask them about their experience and outcomes of care could be empowering. I'm not sure. I think that we do see evidence, and I did touch on this in my presentation, that just the act of asking patients about their outcomes of care improves their outcomes of care. And that there could be a lot of reasons for that. I'm not sure if that's an example of empowering a patient, but what it does a couple of things. I mean, that could be a Hawthorne effect, but that could be because engaging patients, it is a way of engaging patients in their care. And it's just another little nugget of control. It makes patients and people feel like that they have some control, that they have some involvement in their care. Again, I don't know if that's empowering patients. I kind of feel it is. I feel somewhat passionate about the use of these data, but I hope that answers your question. I don't really know, but I do think that just even involving them, we don't do that at all right now. And I also feel pretty passionate about the systematic inclusion. I think all these other surveys and tools are so important, but having a simplified, systematic, standardized process where everybody is included and we do our best to reach those hard to reach groups, and all this data is collected as part of an EMR and a tool that we can use on a regular basis to help inform care, to me, that's pretty powerful.
To add also, just I like talking to patients. I think it all comes down to respect, seeing those people as people, not just their disease. If you talk to them as people first and not disease, I think they are more willing to open up and be able to share more.
That sounds like a great message to end this on. I know we're coming up to 2 o'clock. So a big thank you to Mpho and Sarah for their presentation today. Like I said, I know I learned a lot. I think that none of this is simple, so the questions kind of reflected that. But I think that there was some great discussion there. So thanks for your answers, and thanks to everyone who submitted questions as well. Also, thank you to Brittany for managing things behind the scenes and keeping the questions organized and everything that went along with that. Just a quick note to all attendees that we'll be sending out a survey following the event. We really like to get your thoughts and your feedback on how we can have these events and how we can improve them in the future. So please complete the survey. It should only take a few minutes. That includes our workshop for today. So we hope to see everybody at future SCPOR workshops.
Thank you very much for the opportunity.